Well, first off, thanks to June and John for all the arrangements and technical work to get things set up here. It's nice to be back here. I think it's been a few years at least since I was last came to Lunch and Learn, and I thought we could share some information about myths and facts regarding colon health. You can click to the next slide here. I thought where else to start now in 2023 with looking up common myths and facts, and then with ChatGPT. So you can see they're list top 10 myths regarding yes, we can. Here are, you can hold it here for a second. So a little small, but this is I think not a bad selection of myths regarding colon health. The first two, apparently, top of the list are colon cleanses. I have no firsthand experience with colon cleanses. This is not something that is recommended by doctors or offered at ACMC. It's just kind of all off the non-FDA approved therapies, which people apparently like because they're paying for these things. I can show you some pictures later on about how that looks, but basically no evidence that this is helpful, beneficial, and actually maybe dangerous. So I would agree. The colon can do its own job of getting rid of waste. That's what it's there for. That's how it's designed and evolved. And you don't have to go through these extra procedures to do any kind of health benefits for that. I would not necessarily have gone with 3, but apparently ChatGPT thought that was a thing, that colon cancer only affects men. It does affect women and men as well. There's higher risk than they have, but it's not only men that have to worry about colon cancer and preventing it. Bowel movements should always be daily. Not true. And that is kind of maybe somewhat of a myth. That there's a range, and typically it's thought that up to 3 bowel movements a day, or one every 3 days, kind of average range. But there can be a lot of variability with that. There are no hard and set rules for what has to be done. As long as it's functioning well, it's not causing problems with day to day and work and causing symptoms, that's not really something that has to be that precisely regulated. As long as it's working well. Colonoscopies are painful and risky, so I would agree with say here that modern colonoscopy procedures are typically well tolerated, and with the use of sedation, the risk of complications are low. So well stated there. Number 6, they have eating nuts and seeds causes diverticulitis, and they consider that a myth, saying that there is no conclusive evidence that consuming nuts and seeds directly causes diverticulitis. In fact, they may even have protective effects. I'll show you some pictures later on about diverticulosis and more information about that. But I would take issue with this. It used to be thought that maybe nuts and seeds and corn cause diverticulosis, and that does not seem to be likely by current evidence. But it may even be protective. Having a high fiber diet may be helpful. And they're not entirely sure still exactly why diverticulosis happens, but they're common. Although I have had patients anecdotally say that they are 100% sure that what they ate, provoked a flare of diverticulitis on some occasions. A whole bag of popcorn in one setting, and they had problems in the past and knew that there was going to be problems. Sure enough, the next day they had diverticulitis. Or another patient had a whole bag of frozen blueberries while watching TV. And he convinced that caused the flare. So I think that while there's not evidence that they cause the diverticulosis, the pockets to form, in some patients probably they're at risk for inflammation and diverticulitis from these types of foods. Number 7, colon cancer is always hereditary. While genes can play a role in colon cancer, yes, the majority of colon cancer are not people who have a history of family history of colon cancer. So about 70% of colon cancer is in people that have never had a family history of colon cancer before. But there is a genetic role in some cases. I'm too young for colon cancer. Colon cancer can affect individuals at any age, although it certainly is more common in the over 50 crowd. It is known to be not infrequent in younger patients. That's why the age for routine screening colonoscopy has been lowered by some of the main recommendation societies to 45 years. You may remember the actor in Black Panther, Chadwick Boseman, died at 43 from colon cancer diagnosed when he was 39. So he lived it for 4 years. It was already advanced beyond the colon, and he ended up passing from that and could not film Black Panther 2. But unfortunate for him, he started for 4 years after surgery and chemotherapy. But yeah, so it can happen at any age. I'd say pretty rare under 20, but under 50 is still a possibility. Number 9, only those with symptoms need colonoscopies. Screening colonoscopies are recommended without symptoms to prevent problems before they arise. Once you already have symptoms, that's a sign there may be more advanced disease, and so everybody should have an average risk of having colonoscopies by 45 or other colon cancer screening. And lastly, eating red meat always leads to colon cancer. Clearly not true. Definitely a myth. Well, there may be some increased risks among other factors for colon cancer. Moderate consumption may not have the same effect. So as everything in moderation. And I think we can go on to some other slides here. So as I suggested, this is a picture of a non-medical facility offering these colonics or colon hydrotherapy. You can see some pretty serious looking equipment over here, dials and cables and whatnot. This has been shown to not always be safe and no proven benefits. So some of these use like enemas, like very strong enemas. Sometimes they have people offer like herbal mixes inside of that. Others even advertise coffee colonics. I don't know if they charge extra for the caramel macchiato colonic, but it's other ways to get your caffeine fix than through a colonic enema will be recommended. So yeah, that's something done here at ACMC. So some facts about colon cancer: it is the second most common cause of cancer-related deaths, around 8% of all cancer deaths, behind lung and prostate cancer in men and breast and lung in women. Lifetime incidence is about 4.5%. That's for patients that have not had screening. I think typically 90% occur after age 50. But again, there's a fair number of patients under 50 that need to screen as well. But a third of those who are diagnosed with colon cancer will pass due to that disease. So it is something which you want to catch early because if you catch a polyp, before cancer, that is curative. That polyp is gone, it's not going to cause problems. If you catch a colon cancer early before it advances, localized to the colon, that can be curative as well. Once it's involved in lymph nodes and other sites, obviously the possibility of cure is not a given. Screening does save lives, and deaths in colon cancer have decreased an average of 2.7, almost 3% yearly over the past years. And so the majority of that is due to screening. More screening, better screening. So this is a story of success. That we've had. This is a cancer that is deadly. It's common. It's widespread, and it can be prevented. So we're making good progress with that. Here you see a nice slide that shows some of the risks that increase for colon cancer in a family history. So baseline, you can see a 1.0. It's going to be the person with no known family history of colon cancer polyps. So that's the average risk, and it increases by more than double if there is any first-degree relative. So a person has a parent, one parent that had colon cancer at whatever age, or a sibling. So they're at over twice the risk for colon cancer than someone who doesn't. But then if they had a relative with colon cancer diagnosed at less than age 45, so a younger age, that risk shoots up to almost 4. So 4 times the average risk. So if a parent, say a parent, is diagnosed with colon cancer at age 80 or something, older, less of a risk, but still increased. If they were diagnosed at a younger age, the risk is higher. Probably because there's more significant genes at play, and so there's a higher risk of relatives having colon cancer too. Last slide there showed the highest risk was with 2 relatives who had more than 1 relative, so that's even a higher risk. So the younger age, closer relatives, and the number of relatives are all indications about some increased risks. So we go on to the next slide. And here's a nice table with some of the factors associated with increased risk and decreased risk for colon cancer. And honestly, the biggest ones here, the lack of physical activity is a risk factor for a lot of disease. Obesity, cigarette smoking, probably the main ones as well. Decreased risk, aspirin can decrease risk for colon cancer in those at really high risks. These are only really been shown to be beneficial in these polyposis syndromes. These are not so common syndromes, but the pathways in the body that lead to these gene effects can be minimized with aspirin and other medications like that. Multivitamins, calcium, fruits and vegetables, fiber. That's probably the biggest thing really for most people. Healthy lifestyle is not just healthy for our heart disease and our joints and all of that, but actually can decrease our cancer risk and colon cancer as well. So all the more reason to encourage the activities going on here for your fitness. Not that you need more reasons, but add it to the bucket. So there are other. So besides for colonoscopy, there are other testing that can be helpful. Colon cancer is probably the most asked about in the last number of years. Cologuard test, the home-based stool test. You may have seen the ad, the little smiley face on 2 legs, and there's a Saturday Night Live joke about that as well. But the older one was a fecal occult blood test looking for trace blood in the stool because polyps can bleed. And so if you're not seeing actual blood, there could be trace blood there. So that's what that looks for. A FIT test is a fecal chemical test. It's a little bit more sensitive than the regular occult blood test. Cologuard looks for blood and it looks for certain genes called KRAS that are shed as certain colon polyps. More on the right side. So it kind of increases the helpfulness of the test. CT colonography is a special CT done with after a bowel prep. So the patient has to have a bowel prep first. They create like a virtual colonoscopy where they can look for polyps or lesions in the colon better than a regular CT the abdomen would show. It's some radiation involved because this is a CT test. There's a bowel prep needed for it. If they find a polyp, then you have to do another bowel prep for a colonoscopy. So it's not the preferred test for most patients, but sometimes where they can't have a full colonoscopy or they're too high risk for whatever reasons, that is available. A capsule study is done as well, where you got to do a bowel prep and then swallow a capsule, looks at the colon. Not currently offered here at ACMC. Sigmoidoscopy with or without FIT testing has been done in the past. But I'll show you another slide coming up here comparing all these tests. So this is colonoscopy, FIT every year, CT colon every 5 years, a sigmoidoscopy every 5 years, a occult blood test, and a FIT DNA, which is like a Cologuard test. So you can see that for small polyps, medium polyps, large polyps, and colon cancer, colonoscopy is by far away the most helpful of these tests. The stool-based tests you can see here, here, and here. Various ability to find colon cancer. Cologuard is the best of those. You can see 73%, 4%, 70%, 92%. And it does okay at finding large polyps. 95% with the colonoscopy versus 42% with the Cologuard. So clearly, not as optimal for that, and really not good at all for small polyps. Here it is, 85% for medium polyp, and this is 17%. So it's done every 3 years typically. This is every year. This is every 3 years, it's basically looking for concerning polyps. So once you have a concerning polyp, it already could be a cancer. It already could be a polyp that might be surgery. So it has some downside. CAT scan is good at finding large polyps and colon cancers. Not quite as good as colonoscopy, but it's non-invasive. It has the risks of radiation, and you need to have multiple bowel preps. So that is, I think, a good summary of why colonoscopy is still the preferred modality for screening for most patients. Well, it does require a sedation and a day off from work. But in terms of efficacy of the test, being able to evaluate and get it taken care of at the same time, clear benefits for colonoscopy. Any questions, by the way? Feel free to chime in, or yes?
I'm reading my list over here, so I thought it was going to be at the end. So for the Cologuard, do you recommend all of them need a bowel prep? Correct?
No.
Which one does
Stool-based tests do not.
They do not. So
Nope,
Cologuard would not need a bowel prep.
Correct.
Okay.
That's probably the biggest thing, the biggest advantage with those stool-based tests.
Say, the worst part of colonoscopy is the bowel prep.
The doctor would order the test. They would put a mail to your house with a kit inside. You mail it back through UPS. I think they arrange for shipping to pick it up, and sort of parameters for how it's collected and how many days and whatnot. And then the doctor will get a result back with a positive or a negative.
If somebody had somebody in their family, their father had colon cancer, but there's a risk for them being put under sedation, would it be something that they would recommend the Cologuard?
Cologuard was not studied in the high-risk population.
Okay.
Family history or people that have had previous colon polyps with a higher risk. So in theory, it's looking for the same things.
Right.
But the cutoffs for how sensitive, how specific, how some of the higher risk, you may have a higher concern for not missing a cancer polyp.
Right.
And that's where those numbers get thrown off.
Right.
Because this is all based on average risk.
Right.
So if you have a positive result, you're going to want a colonoscopy to evaluate.
Right.
The negative result, that's where you have to wonder is, are you comfortable and some of the higher risk with that normal result? Or are you going to be a little bit wondering, are you just questioning if it's something there that should be checked out? So in that population, a colonoscopy is recommended.
Okay, so both of my children, their two grandfathers on both sides had colon cancer. They're now going close to 40. Would they recommend them to get screening earlier?
Yeah, you should talk to the doctor about. Probably around 40.
Yeah, I was wondering if with the fact that both their grandparents, paternal and maternal, had colon cancer, maybe they should get
2 secondary relatives.
Yeah.
I think that's a good idea.
Okay. I guess I'm on my way
Yeah.
today and
Anything else? Okay. Guys, we'll have more questions later on too. So why not a sequencoscopy? This was a very common test done in the past, before I started practicing. Talking about in the 80s, and you can see here the extent of where a sequencoscopy reaches. So this is the anus here. Its scope is inserted, and it gets through the sigmoid, maybe the descending colon up here, up to the splenic flexure, possibly or so. That's as far as scope goes. So if you have polyps down here, they can see and remove them. And you can see here how the scope looks head on. You can see it's got a port for irrigation, the video camera, a light, instrument channel, also used for suctioning as well. So you can suction polyps out when they're removed, or liquids or whatnot. That's kind of how a picture how the colon looks. It's a normal looking colon there. And then the next picture is, well, this is a very reason why you don't just order Gastroenterologist. This is a colon cancer. And this is located right over here. So that would not be seen with sigmoidoscopy. You can see, you're just seeing up to here the most recently. So it's way on the other side, but a colonoscopy would. You would see this whole area, maybe a small bowel above here too. That's the appendix down there. That's not evaluated for colonoscopy, but you see a colon on the other side. But this would need surgery. Basically we need to have that portion of the colon. This is a diagram of a illustration of a held polyp is removed. So through the instrument channel, catheters can be passed, a biopsy, forceps for example, or a smear as in this case. And this is a polyp that has a stalk to it. The stalk is not polyp. So in this case, the stalk can be lassoed and then cauterized or cut, and the polyp is suctioned out with through the scope and off to the lab to be evaluated. This is a smaller polyp with a similar picture there. This is a catheter that's pushed through the scope. This is a smear right here going around that polyp. This is a pretty small polyp actually, probably like a centimeter in size, but that's how that looks. Colon cancer warning signs apply to anybody, even someone younger than 50 or 45, or any age. Change in bowel habits. Now this is kind of a gray area because everyone's bowel habits change over time, but this is more like something which is either a significant change or something which is not resolving with the usual measures, and that can be typically constipation, or smaller, narrow stools, things like that. Which don't seem right. Rectal bleeding, as colon cancer polyps can bleed. Unexplained lower abdominal pain, just an ache in the abdomen somewhere. It's not explained, not going away with usual care. So I think that any kind of GI symptom that doesn't seem normal, that makes aches and pains here and there, but this time this is more than average or not going away. Should prompt consideration of why. And unexplained iron deficiency anemia, and as you even have someone that has no bleeding, but they're slowly losing blood, and that can be a source anywhere in the GI tract, including colon too. And that'd be another reason to have a colonoscopy or another evaluation of it. So the bowel prep is probably everyone's least favorite part of the experience of colonoscopy. Wow, this prep is so delicious. I think I'll have it. I'll drink another. Said no one ever, and that's still the case. But they have gotten better. As you can see, the next slide. This is the old-fashioned go lightly or co-light or new lightly, which is 4-liter jugs that powder mixed in with water, and they taste terrible, and everyone hates drinking it for the most part. And it's a large amount. It's 4 liters. This is 6 ounces. So it's called Plenpick, for example. There's a few newer, smaller ones. 6 ounces. Plenpick also is a smaller volume too. There's tablets. A lot of tablets. It's 24 tablets, but if people don't want to drink water or liquids, that's an option as well. Movie Prep is a little smaller, it's about 2 liters. Not as small as these. New one just came out. Souffle. They say it's like a lemon lime flavoring. So there's a little variety of options now that are more palatable than go lightly. I have tasted this. It's not bad. I would still recommend a straw with it. You don't want to be, you're not going to be like, chugging it down and enjoying it. But they say, people who have tried both say this is much better than these preps. And tolerated. Here's a picture of diverticulosis. You can see these little pockets here. They're not inflamed, it's not diverticulitis. It's just a healthy looking colon with diverticulosis. And when they get inflamed, these can get thickened, congested, narrow, they can get infected as well. But what they are is sac-like protrusions of the colonic mucosa through a weak point in the wall, muscular wall of the colon. So it's just like an area that's gotten weak over time. They think that this might be due to inflammation at times, maybe some genetic factors. Not entirely clear how exactly why, but they are often asymptomatic. People just have them and it doesn't cause any problems at all. But they can become diseased with pain, bleeding, or infection. They can rupture, requiring surgery or even emergency surgery. About 4% of people have diverticulitis, develop diverticulitis, which is when they're inflamed, either one or several diverticula. The number and size of diverticula increase with age. About 40 to 60% of people have some by age 60. So again, pretty common, not necessarily abnormal to have some, but can cause problems. They are associated with male gender, obesity, low levels of vigorous activity, smoking, alcohol consumption, diets high in red meat, and probably NSAID use as well. That's like frequent ibuprofen type medications. So you can see a lot of overlap with these risk factors and colon cancer as well. Not statistically increased with consumption of corn or nuts, like we talked about earlier. Any questions about that? Okay. In terms of probiotics are a big field right now. Multi-million or billion-dollar industry. They're in all kinds of foods and snacks and medications. Not really clear how much health benefits these have in the long term. They may be helpful in short-term use for like infectious diarrhea, shortening the symptoms, helping with symptoms, or in preventing diarrhea from antibiotics. Some of the ones that are good for that are Culturelle or Florastor. There are some that are used in certain inflammatory bowel disease conditions, called VSL number 3, which is a combination of probiotics. The best ones are typically kept in the refrigerator because they are alive, they're probiotics. And if they're on a pill on the shelf, probably not as good. So yogurt's a great source. If you have, various yogurts that have probiotics, that's probably very good because they're in the fridge, they're alive. A lot of these effects are temporary. They don't have people's bodies are have their own DNA makeup of their, not DNA, but their own bio makeup of their amounts and types of bacteria, and that's perpetuated. So you can alter temporarily, but if your diet doesn't change that much, your old bacteria come back to the way they were before. You stop probiotics. So there's a memory there in the ecosystem, and you can temporarily affect it, but not long term. You're looking at things called probiotic spores, which are the precursors, like little, and that we can get in many more spores than probiotics, especially more. That may have more effects, but in general, it's mostly symptomatic. It's just a matter of something like bloating or diarrhea or constipation, and it's worth a try to see if any of these things help with that. Obstacles to colonoscopy. I think this is a good slide to summarize. People just don't want to go. It's like, am I going to the IRS for tax prep today or the colonoscopy office? I think that hopefully with education and explanation, while you still might not want to go to the IRS tax prep office, you won't have as much fear coming to the colonoscopy office. This is where the office is right across the street. Jerry Berg is an NP there most days of the week. To know that myself. Office 1 day a week, and then the 4th floor ACMC for endoscopies and colonoscopies and such. So those are the slides I have prepared. I'm happy to answer any other questions or comments, or if you want to chime in with any thoughts.
So you were talking about like food to eat and stuff, like to have a calcium supplement. So what if your diet is higher in calcium? Like if you can't take, you eat enough dairy that you have calcium.
Yeah, diet's always the best source for vitamins. You're getting the other vitamins too, and fiber probably as well. So yeah.
So what's your source for fiber? Like I eat flaxseed every day in a smoothie. Do you feel that's enough fiber?
Yeah, I think fruits and vegetables, are high in fiber.
Okay.
So if it's prunes or apples or a lot of other whatever you like. I think there's the best diet is a diet that's varied. Not just one food group. So I think getting fresh produce in season is going to taste better. It's going to last longer. You'll actually eat it. So I think buying things that are in season, ideally, or fresh, and a variety. I think that's the best is getting all your vitamins and sources. Not relying. Basically, you don't want to have very high carbohydrate, processed, food diet. So the more whole foods, the better. So it's, for example, having an orange over orange juice. If it's the whole orange juice, that's you're getting fiber too. If it's just the juice, you're missing out on all that fiber. Apple juice and apples. So more things from the periphery of the grocery store, and less things from the center. They say, right? That's tend to be all the cereal. Some cereal are fine, but a lot of the processed foods and cookies and cakes and all that in the center, and then you have your fresh produce all on the outside. So,
what about the fermented probiotics, like the sauerkraut and all that? Do you feel that is just as good as
there's a lot of talk about that. I know I've read some writings of proponents for that. Mostly, I think, for the probiotic standpoint, and it seems reasonable. I don't know if there's a ton of health benefits proven, but if it's safe and if it works for you, sure, why not?
You never know. You really don't know what it's the trend of the season or whatever.
I think it's an okay trend. I wouldn't be worried about it.
I know.
Will it be a fad, or will it be in fashion 10 years from now? I don't know. But if you enjoy it and it's definitely doesn't seem to be bad. So
here we get people with all kinds of opinions about nutrition and what to eat and what shouldn't eat, and so we hear all of the different trends. So it's nice to get a doctor's opinion on what is the right way. Of course we know the tried and true for sure.
Yeah, Mediterranean diet has been the best studied diet, and it's pretty easy to implement as well.
Good. Okay. So, but the Mediterranean diet isn't about a lot of protein, though. More so from like beans and
more lean protein to fish and lean meats.
Right. Right. I mean, that's been around for years.
Right. It's not this like high protein diet.
Let's see, that's the new trend. There's a higher protein diets.
Fiber seems really good for a lot of things in the body. So I think that whatever diet you're on, you want to make sure you're getting whole foods and that fiber.